In a world that has been battered by COVID, we are now looking forward to building back better, in the words of the United Nations and the World Health Organization. However, we do need to build forward better because we cannot go back to old systems which have failed us. And therefore, we ought to see how we can build our health systems as well as our social systems forward, broader, better, and fairer. Indeed, COVID-19 has given us many lessons. First one is that health systems which are not efficient and equitable to begin with in the steady state before the pandemic failed to create a swift and strong surge response in the face of a public health emergency. Countries and states of India which had better functioning health systems coped better, even they too were challenged by the magnitude of the pandemic. Second, we also recognize that unless countries have a strong public sector presence in their health systems, they cannot really discharge the functions of delivering acceptable, available, and affordable healthcare to all sections of the people, even during periods without an emergency, but particularly during a public health emergency, the health system cannot function in terms of efficient and equitable delivery of health services. Third, we recognize that primary healthcare systems are particularly important in terms of building a stronger health system which can deliver universal health coverage to all of its people in any country. Building on these lessons, we must look at how India has evolved its health system over the decades of its independence, where the fault lines lie, and how we can actually improve upon the structure, functioning, and accountability of our health system. Firstly, for that, we must look at where India's health indicators lie. If we are really looking at our health indicators as a reflection of the efficient and equitable dimensions of our health system performance, then we have a great deal of cause for concern. The reasons are simple. Even if you compare India with the neighboring countries, we find that in India, infant mortality is around 30 per 1,000 live births, whereas in Sri Lanka it is 6, in Bangladesh it is 25, in China it is 7.4. If you look at life expectancy as a cumulative measure of how health has been really looked after by the society of all its citizens, then India's life expectancy is 69.2 years. In Sri Lanka, it is 77 years. In Bangladesh, it is 72 years. In China, it is 76.5 years. Even Nepal has a higher life expectancy than in India. So, it is not just economic development alone that matters, because we are better developed than some of our South Asian neighbors, but the manner in which the health system has been configured to deliver health services to all of the citizens in an efficient and equitable manner that matters. And here we must recognize that we have underinvested, grossly underinvested in our health system in terms of public financing of health. If you look at comparative expenditure on health across different countries and look at total health expenditure as well as government's contribution to that health expenditure, then we see that in India, all the healthcare expenditure, the government contributes only 30%, whereas in Sri Lanka it is about 56%, In China, again, it's close to 60% now. In Brazil, it is 46%. In Japan, it is 83.6%. In Germany, it is 77%. In Thailand, it is 77.8%. In the UK, which has the National Health Service, it is 83%. Even in the United States of America, which is seen as the poster child for privatized medical care, the public financing or government expenditure on healthcare is 48.3%, and compare that with India at 30%. And as a result, we have very high levels of out-of-pocket expenditure. India's out-of-pocket expenditure over the past 3 decades has hovered between 60 and 75%. Now it is considered to be closer to 58%, but nevertheless it's very high. That means this is what a person has to spend out of pocket for his or her health care. In Sri Lanka, it is 42%, in China, it is 32%, in Japan, it's 14%, in Thailand, it's 11.9%, in the UK, it's 9.7%. So, if we really look at how we are faring in terms of out-of-pocket expenditure in comparison to other countries, government health expenditure as a proportion of total health expenditure, India ranks 176 out of 191 countries in the world. Whereas when you look at out-of-pocket expenditure, India ranks in terms of the high burden of out-of-pocket expenditure in the top 10 countries. That means if you look at low out-of-pocket expenditure and rank countries according to that, then India is 182 out of 191 countries. And this is a great cause for concern, because an under-resourced health system cannot perform efficiently to deliver the healthcare needs of all of its people. So there will be a great deal of health problems which will occur, and particularly among the poorer and the vulnerable sections of the people. And if we look at different states of India, again we find there is a considerable difference in the way the states too have been spending on health. And states which have invested more in health, and particularly in the delivery of health services through a strong public sector, like Kerala and Tamil Nadu and some of the southern states, have done generally well, whereas the states in central and northern India and the northeast, which have underinvested in health and particularly ignored the public sector, have not done well either before the pandemic or during the pandemic. If you look at the state expenditures of UP, Bihar, then it is about 800 to 1000 rupees per capita, per person per year. Whereas in Goa it is about 6,000, in Arunachal Pradesh it is 10,000. So there are differences across the country, but in general, if you take the proportion of health as a part of the health overall budget of the states, then some of the southern states have spent much more than some of the northern and central Indian states, and particularly the southern states and some of these other states, including Himachal Pradesh, have focused on strengthening the public sector services. And our insurance schemes, which are much talked about, really do not contribute much. Private insurance contributes to only about 10%. Government insurance contributes to only about 26.5% of coverage at the moment. And we recognize that many of the people do not have financial protection when challenged with a severe healthcare problem. Either they get a catastrophic impact on their finances and are pushed into poverty, or even if they have to spend chronically on a long term for care, like for example diabetes, high blood pressure, or other conditions which require lifelong care, then the out-of-pocket expenditure again pushes them into poverty. And we have seen this happening. For example, we have seen in different surveys of the National Sample Survey Organization conducted between 2004 and 2014, that despite some of the so-called health insurance schemes coming up from the government, both at the central level and the state level, 7% of India's population were at the risk of being pushed into poverty because of healthcare expenditure alone. It is one of the major causes of poverty in India. And at the same time, apart from the financing aspect of it, we find that there is a great deal of asymmetry in the availability of healthcare providers in India. Overall, there are huge shortages all across India, but there are also huge asymmetries among the states and between urban and rural areas. For example, if you look at the health workforce, which consist of doctors, nurses, midwives, and of course allied health professionals, there is a shortage of doctors because whereas the global norm is 1 doctor per 1,000 population, we find 1 doctor per 1,511 persons in India. Similarly, in nurses, it is 1:670 that we have, whereas the global norm is about 1:500. Combining doctors, nurses, and midwives, the World Health Organization estimates that we need about 44.5 of these 3 categories of healthcare providers per 10,000 population in order to deliver universal health coverage and meet the Sustainable Development Goals. We have just about half that number, about 22 per 10,000. Therefore, we do need many more people at various levels, right from community health workers to various allied health professionals or medical technicians to basic doctors, specialist doctors, and of course, we need to ensure that public health expertise is also greatly developed, because we have seen the lack of public health expertise failing us during the COVID pandemic, right from planning to delivery of services. So we must correct some of these gross distortions that are there, but we must also recognize that there is a huge amount of maldistribution across states. If you take the healthcare workforce, then we find that while 2/3 of our population is living in rural areas, 2/3 of doctors, nurses, and other allied health professionals are actually working in urban areas. It's exactly the reverse. And even the Indian systems of medicine, Ayush, we find they are also mostly in urban areas, very few in a proper manner distributed across rural areas. And while we have invested in rural primary health care, urban primary health care does not really exist in most of the cities in an organized manner. And therefore, people have to depend upon either the private hospitals or the high-end tertiary care hospitals of the government for primary care needs, or go to quacks if they are from the low-income community and live in urban slums. And this will not really protect our health. So we need more training institutions which are well distributed across the country. About 60% or more of our medical colleges are concentrated in the 4 South Indian states and in Western India, whereas in Central India, Northern India, Northeast India, the medical colleges are very few in number and do not train adequate number of undergraduate and postgraduate doctors. So we need to correct several of these distortions as we go along. Let me come to why this has happened. India started off fairly well with a strong commitment to universal health coverage, or care better, right from the period of independence. It had a strong emphasis on the public sector. We found that whether it was a primary care center or a government hospital in the city, care was being provided mostly free by the public sector. However, under-resourcing, under-financing of the public sector, with also reduced number of people in terms of the health workforce, poor governance, all of this saw the public sector dwindle in terms of its presence and decline in terms of its performance. And with economic liberalization, we saw the private sector coming up in a big way, starting with the 1980s, but really roaring into a largely dominant urban presence in from 1990 onwards. Now, much of the care is now being provided by the private sector, by the organized private sector, as well as the informal private sector in tertiary care, secondary care, and even to some extent in the primary care. Though in the primary care, it's not very well organized in terms of providing the care in rural areas and small towns, and that we have seen during COVID. And indeed, in COVID, we saw how the dependence on the private sector hurt us in India. Not only they were unable to deliver the care in smaller towns and villages, but the exorbitant rates charged by some of them in urban areas were scandalous, and they could not even provide adequate amount of beds for admission and even ran short of oxygen supply because they are not prepared for it. That of course affected the government sector as well, which indicates again poor governance and preparation of entire health sector for public health emergencies. But one of the stark failures of the private sector came into visibility when they were asked to deal with 25% of the vaccines in India. They were permitted to acquire 25% vaccines and administer them. And we found that beyond few large hospitals in large cities, they could not really deliver more than 7% of the vaccines, especially in small towns and villages. So over-dependence on the private sector can be very costly for public health and overall efficiency and equity of health care. But we have evolved a mixed health system over the years by default and not by design. And therefore, we have to possibly accommodate all the sectors, public, private, as well as voluntary sectors, under a framework of universal health coverage, which we need to evolve. But with appropriate regulatory framework, with clearly defined deliverables and accountability mechanisms. You cannot have a private sector that is under-regulated or unregulated and have a completely under-resourced public sector having to struggle with delivering the care both to a vast majority of people who cannot afford health care by out-of-pocket expenses, or particularly deliver most of the services during a public health emergency. So we need to strengthen our public sector. We need to make our private sector more responsible partner in the universal health coverage, but with clear-cut accountability mechanisms and a strong regulatory structure. But this requires us to look at universal health coverage. What is universal health coverage? It is now something that has been committed to by the Sustainable Development Goals, and we have signed up to it as a country, and we have also incorporated that in our National Health Policy of 2017. So we see that we do require to focus on universal health coverage as a system where every person living in the country gets all the essential health services, all the health services that he or she needs with assured quality, but without suffering financial hardship. That means there should be no high out-of-pocket expenditure. There is no catastrophic health expenditure which pushes them into poverty if there is a health emergency or a serious health condition. Now, that appears to be a bit of a tall order, because we cannot overnight provide all the services to everybody who needs it immediately unless we raise our public financing of health. And therefore, while our public financing of health has stagnated around 1.4% of our entire gross domestic product, the government too has committed that we must raise it to at least 2.5% of our GDP. We possibly will require a minimum of 3% of our GDP in order to deliver reasonable amount of healthcare services, and that is public financing. It can be supplemented by government supported social and health insurance programs to some extent, employer provided insurance, as well as privately purchased insurance. But the bulk of it has to come from tax funded government funding. Without that, we will not be able to maintain our health services at the level of efficiency that is required to deliver all the services. But we recognize that we cannot immediately gather all the resources needed for a full-fledged universal health coverage overnight. So we have to progressively develop that, and therefore there are three dimensions of universal health coverage which are described by the World Health Organization. One is population coverage. That is what proportion of people are being covered by the universal health coverage program. Second is service coverage. What are the services included in the package of services that are prepared under universal health coverage and which are guaranteed for delivery by the government? Whether the government is going to do it through the public sector or also through the private sector which has been contracted, that's a different issue. But the government is responsible for making sure that those services are delivered. The third is what's called cost coverage. How much of the cost of this financing from out of pocket is going to be reduced and how much of it is going to be without a financial burden on people. So cost coverage is important, but at the same time you have to make sure that you are spending that money well so that it is not unproductive expenditure or on unnecessary procedures, and that while reducing poverty levels in the people because of health care, you are also keeping the health budget reasonably under check so that you are not guilty of imprudent financial expenditure. So these three aspects will have to be balanced. Politicians generally go in for population coverage because even if the services are few, they'd like to please many people. The healthcare providers like doctors would like to go in for a broad service coverage package because they feel that their patients deserve the best, however expensive it is. Whereas the economists who are usually in the Niti Aayog or Planning Commission, as well as the health system managers like the health secretaries and others, the civil servants and the other economists, usually look at the cost coverage and say, how much can we actually provide for the universal health coverage packet to provide the maximum benefits possible with the best impact on reducing poverty related to health care while keeping the overall budget reasonably under check. So poverty reduction and fiscal prudence are the guidelines there. So there's a dynamic tension between these three perspectives, and at any given time, based on the resources available, we have to balance all three of them. However, there's one other element that comes in. It's not just cost effectiveness of the interventions or the service components that we are providing that we need to look at, though that's very important. We need to look at what is also the burden of disease, which are the common health conditions, which are the health conditions that people mostly suffer from, how do we address that, how do we provide services for that, all of that we need to look at. But we also need to look at what's called the equity dimension. Who are the vulnerable groups who are most disadvantaged already, who are suffering already from poor health conditions, who are unable to access health services properly because of poverty, disability, or because of a variety of other reasons by which they are disadvantaged or discriminated. So a universal health coverage program has also to bring in that dimension to bridge the health equity gaps. So you have two different dimensions. One is what can be called the horizontal equity, in which everybody gets the same set of services, like primary health care, much of secondary health care, life-saving elements of advanced health care. But there are groups that will be prioritized for additional resources or additional services to reduce the existing health equity gaps. So that would be seen as vertical equity. So we need to balance both of these when we are configuring a universal health coverage package. But UHC is the best platform on which we can provide services for many of India's health conditions, right from health promotion, how to build health better so that people don't fall ill, how to undertake preventive measures so that even when there are some problems coming up, whether it's an infection or whether it's the temptation of tobacco addiction, we are actually preventing these things from happening and causing disease. Or how do we detect blood pressure and diabetes early before it goes on to kidney failure or heart attacks? So both health promotion and prevention are very important, both at the population level and at the individual level. But we also need early detection of disease or of risk factors of disease and effective prompt care so that they do not proceed to advanced disease, which is going to be costly and will cut short life expectancy or cause a huge amount of disability. We also need rehabilitative services. We need palliative care for people in extreme ends of terminal disease. And we recognize that health challenges in India are changing. Our infectious diseases have generally come down over the last 3 decades, whereas non-communicable diseases like heart diseases, diabetes, cancers, chronic respiratory disease, mental illness, all of them have gone up. It's not that infectious diseases have completely gone away. Tuberculosis is still a major challenge. We see malaria, we see dengue, we see chikungunya, but overall, these challenges have become less. We also see huge nutritional challenges. About 38% of our children are still stunted, and very many are wasted and also undernourished. So given the huge problem that we are seeing in terms of nutritional deficiencies in our children, many of our women in the reproductive age group and children under 5 are anemic. So we have a problem of undernutrition, we have a problem of infectious diseases. At the same time, we are seeing chronic diseases like heart diseases, diabetes, cancers, chronic lung diseases, all of them rising quite rapidly. So in order to address all of these challenges, you need a very efficient health system, and that needs to be well resourced, not only in terms of financing, but also in terms of healthcare delivery services. Of course, technologies will help. We should be able to use our healthcare technologies, particularly in primary care, to enable non-doctors like community health workers, nurses, and auxiliary nurse midwives, and mid-level healthcare providers whom we are developing now to efficiently use technology for delivering services. But technology alone will not solve the problem. You still need human resources at the front end to use that technology and to connect with telehealth services with advanced health care. Depending only on technologies will get us nowhere, but we should use our technologies wisely and well, while investing in well-trained human resources at different levels. And we must develop our district hospitals as well. We must particularly focus on our primary care, both in rural areas and in urban areas, because as I said, urban primary health care has been neglected for long, right from sub-centers to primary health care and community health centers, but also linking them well with district hospitals and medical college hospitals. So we need comprehensive health care at the primary care level, we need continuous care at the primary level, and for people with long-term health problems like diabetes or hypertension, we need chronic care. Of course, we need compassionate care for everybody so that people are treated with courtesy, but we also need connected care where we find that primary care is efficiently connected to secondary care institutions like district hospitals, tertiary care institutions like medical college hospitals, and there is a referral back to primary care after they have been treated for their immediate health problems. Unless we establish all of these structures in a seamless manner, we will find people running from pillar to post whether they have a minor medical problem or a serious medical emergency. So we need to reconfigure our health system by reimagining all of these in a fairly coherent manner. And for that we need very good public health expertise as well, because unless you are able to identify what is likely to be the next pandemic, next infectious disease outbreak, in which part of the country, how do you prevent it, how do you actually manage to prepare your health services to meet that, or even to deliver regular services, how do you actually configure the health system to make sure that there are enough trained, well-motivated and accountable healthcare providers at each level of care, from the sub-center to the district hospital or the medical college hospital. How is the private sector going to be brought in for service delivery in an accountable manner? How is the public sector going to be strengthened so that it can actually become the pace setter for high quality healthcare, which is affordable to everybody? So these are some of the issues that we ought to be really looking at as we rebuild our health system. And we must ensure that some of the inequalities that exist across our country between rural areas and urban areas, between different states, all of them are eliminated. And of course, we must make sure that the most vulnerable groups, whether they are living in urban slums or in rural poverty, are given the highest priority. And the tribal communities of our country who have been having the worst health indicators are also given much greater attention and better services. So all of these are challenges that we need to look at. And when we are really looking at reconfiguring India and reimagining a health system which is much more efficient and equitable, we have to prepare the platform of universal health coverage in order to address all the health challenges and try and ensure that we build systems which can keep people healthy across their life course, but when they do fall ill, then we ought to be able to give them the health care that they require promptly and efficiently. We need better health information systems so that we need data for early decision making, and we need better governance of our health system by the overall management right at the policymaker level to the people who are managing the healthcare facilities. And of course, education is very important. While we must improve the education levels of the people, health literacy must be provided also as a priority so that people can understand their health and nutrition needs and can take decisions to protect, preserve, and promote their own health. So all of these are the social determinants of health. So we need to bring that along with universal health coverage as we rebuild our systems. Finally, as I said, it's not just building back better, going back to the old systems and trying to do more of the same thing. It is building forward better by reimagining how an efficient, equitable, and empathetic health system can be developed. And that will require that we not only build forward better, but broader with a much greater emphasis on primary health services. We also need to broaden the community engagement, but build forward better, broader, and fairer. We must focus on health equity as an important criterion of how we configure and deliver our health services. And that is where we must head forward as we move out of the pandemic into a new era. Thank you very much.